All right, so we're now into week 10 of the semester. This week we take up the topic of healthcare in the US. Let me just point out that this is a rather broad and complicated topic. And so I would encourage students to think in sort of three categories. And so the first of those categories is in the way of health insurance or issues pertaining to access to health insurance, both public and private in the US. And then secondly, there's issues pertaining to access to actual care in the US. And so this is, for example, things like access to doctor visits or overnight hospital stays. And so all of these issues are in the second compartment. And then in the third compartment, we have issues pertaining to population or public health and all the different indicators of the extent to which our population is healthy or not. And so given these three compartments, I just want to point out that this lecture is primarily focused on the first of those three issues, that is issues pertaining to access to health insurance. And so given that focus, let me just provide a quick outline of what we'll be talking about this week. And so in the first part of this lecture, I'll take two selected criteria, that is in the way of adequacy and equity, and I'll provide my brief assessment of the adequacy and the equity that characterizes our current program in the way of access to health insurance. And then in the second part of this lecture, we'll take a more close look at how the programs actually operate, with the primary focus there on our public health insurance programs, namely Medicare and Medicaid. And so we'll take a look at those structural characteristics primarily. And then in the third and last part of this lecture, we'll take up an issue that's been prevalent for decades now in the way of our public health insurance system. That is the challenge pertaining to controlling costs and the related concern with the quality that may be compromised in maintaining costs. And so there's that tension between the balancing of cost and quality that we'll discuss in the third and last part of this lecture. So first, I just want to point out that we have a new system in place, a relatively new system. So this is dating back to 2010 when President Obama signed the Patient Protection and Affordable Care Act into law. So this is a rather comprehensive bill. It spans at least 1,200 pages. At the time of the signing of the legislation, it was 1,200 pages. And then now insiders, that is advocacy organizations around Chicago, will point out that in working on this legislation, it's now up to 2,000 pages. And so that's just a quick point pertaining to the comprehensiveness of the legislation. So certainly no part of the healthcare system that's probably not affected. And so when we think about doctors, nurses, and other providers, they're certainly affected by the new legislation. Consumers are certainly affected in a number of different ways, most notably in the way of the individual responsibility payments, the different penalties that are attached. We'll talk more about this in the later parts of this lecture. And then, of course, indirectly, I think we can make a case that mostly all of us are affected since our tax revenues, our tax payments are used to fund the general taxes, that is, are at least used to fund the Medicaid program, which is the program of last resort. And so certainly there's no part of the current system that remains unaffected by the new legislation. Now, I always have this sort of slide here, this sort of preaching to the choir slide, where I pose a simple question of why do we care? And so this is just off the top of your head. I'm sure you can think about the different ways in which knowledge of healthcare might be relevant to you. And so maybe you're thinking about a future career in a healthcare setting, or at the very least, I guarantee that at some point in your careers, you'll run across a client that's going to ask you a question about the health insurance, the healthcare system. And so once again, this is a case of just preaching to the choir. This is important for our purposes, certainly. All right, and so I had noted in the outline, in my quick description of the outline, that I would provide my brief assessment of the current state of our health insurance system. And so if we're picking two particular criteria here in the way of assessing our health insurance system, in the way of access to health insurance, again, this is not an assessment of access to care, but an assessment of access to health insurance in the U.S. First, in the way of adequacy, I think we can make a strong case that we've done a much better job recently. We're getting much better over the years in the way of ensuring access to health insurance, both public and private. And so just 5 years ago, or I should say maybe let's go back 6 years, So 2009, prior to passage of the Affordable Care Act, we were looking at uninsurance rates of upwards of 15%. These estimates are coming from the National Health Interview Survey, just one of several different data sets that are used by researchers and scholars to assess the rate of uninsurance in the US. And so based on these estimates, we're doing much better currently than what we did prior to implementation of the Affordable Care Act. What was once upwards of 15% is now down to 11.5% as of 2014. And there are different indicators of the rate to which, of the extent to which people are uninsured in the US. There's most notably persistent lack of coverage, those who are uninsured for more than 1 year. This is down to 8.4% as of 2014. So we've made tremendous strides in the way of the adequacy of our health insurance system. There are even more optimistic estimates. When we're looking at census data, another data set, they're pointing out that the 2014 rate of uninsurance, the same rate that was reported as 11.5% in the National Health Interview Survey, is at 10.4% according to the census. Right, so if we're making a quick assessment of the degree to which we're seeing inequities or inequalities in the current system with respect to access to health insurance, there are still many notable disparities in the way of access to health insurance. Certainly in the way of age, we've made tremendous strides. Once again, we've made major improvements here, but historically we've had a huge gap with respect to age disparities, and so this is to point out that mostly the huge gap is in the way of not covering, historically, the working age population, those ages 19 to 64. Now Medicaid, that's partly due to our Medicaid system and the fact that we've never historically provided Medicaid coverage to the working age population until the Affordable Care Act and its implementation in January of 2014 when we expanded Medicaid coverage. We'll talk more about it in the second part of this lecture, but the basic point here is that the working age population is much more likely to be without health insurance coverage relative to kids and older adults. Now, you'll notice here that for older adults, we do a great job of protecting the elderly, where uninsurance rates are typically 1 to 2% for that particular demographic. There are other dimensions of inequities or inequalities, and so we can point out race disparities, income disparities, and also education disparities. In terms of race ethnicity, historically, and I'm referring to the recent past, so Hispanics or Latinos have been much more likely to be without health insurance coverage relative to non-Hispanic whites, upwards of 3 times as likely. But as I'll point out here in a second, in the next slide, we're doing much better in the way of race and ethnic disparities. Income disparities still remain, so certainly those who are poor are much more likely to be without health insurance coverage. What used to be 3 times as likely is now in the way of 2 to 2.5 times as likely to be without health insurance coverage relative to those not poor. And then, of course, we have education disparities as well. Those without a high school education are much more likely to be without health insurance coverage relative to those with higher levels of education. Now, this is just pointing out in numbers what I was just explaining to you, just in layman's terms, just with plain language. And so, if we're looking at age disparities, you see the different rates here. For kids, what we're seeing is under 19, so 18 and under, 6.2%. That's tremendous improvement. Once again, I just want to point out that we're getting much better recently, especially in the last year, because of expansion of Medicaid coverage as of January of 2014, and also with the rolling out of the private health insurance marketplace. Those in the working age category still twice as likely. You see here that the working age population is still twice as likely to be without health insurance coverage, both public and private. We're combining those 2 categories. So twice as likely. And then, of course, we have a separate category for older adults, 1.4% uninsured for older adults. Let me just make a quick note here. This is using the census data, not the National Health Interview survey data, which would probably report numbers that are a little bit higher, but using the more optimistic estimates that are reported by the census, these are the numbers that we're seeing. And then we see the racial ethnic disparities. Still, Hispanics, what used to be upward close to 30% uninsurance rates among Hispanics, Latinos, as of 2014 have dipped tremendously, close to 10 percentage point decrease. And so we're still seeing a 2.5 times as likelihood of being without insurance relative to white, not Hispanic, this category. And so we're making improvements, but there are still disparities that remain. And then finally, one last disparity here. This is in the way of native-born versus foreign-born distinctions. And so the foreign-born population is still somewhere in the order of 2.5 times as likely to be without health insurance coverage in the US. Now, this is not looking at the risk of health insurance within these different demographics, but just looking at composition. So looking at those who are insured and what type of insurance in the US they possess. And so those who claim that our system is socialist in nature, well, this is just one statistic that we can point out, that this is largely a capitalist system, namely that it's mostly in the private sector. You see that most people in the US have private health insurance coverage. 66% of the US still have private health insurance. And if we're looking within that area, so we have employment-based versus just going out and purchasing your own private plan. And so these are the numbers that we're pointing out. 55% employment-based, 14% direct purchase. And then we have our public system, the public composition. That's 16% have Medicare in the US, 19.5% of the US have Medicaid. And this number, if there's any claim to a movement towards a more socialist structure, this number might be the strongest evidence. So we've seen an increase here in the way of Medicaid coverage. And then you have military coverage, and I just pointed out before the rate of uninsurance in the US. All right, so in the next part of this lecture, we're going to dive in to a discussion about Medicare, Medicaid, and the health insurance marketplace.